Our next talk is by Joseph Zwischenberger for Perfusion-Induced Systemic Hyperthermia for Advanced Unresponsive Cancers.
Well, thank you for inviting me. I've been to every one of these symposiums, and I decided this time I'd just go ahead and shock you. So it would be nice. Oh, there we go. Okay, so that's me. I do have some conflicts. I'm the CMO of the company you're going to hear about, but you're going to see why I am and why I'm enthusiastic. Hyperthermia, or a high temperature exposure of cancer cells, has for over decades been known that cancer cells don't have their metabolic act together to tolerate environmental stress. So numerous studies have shown that about 42 degrees centigrade, or 107.6 Fahrenheit, will kill many cancer cells, while normal cells can tolerate that stress. We have about 18 peer-reviewed publications to show we think that's true, and the bottom line is that hyperthermia induces direct cell kill, apoptosis, or senescence to susceptible cell populations. So I've been doing ECMO since most of you were born, and we've developed veno-venous ECMO, and we realized that we can also control temperature. So I developed a technique where we would heat the body to 42 degrees centigrade by perfusing veno-venous. And what we found is that the veno-venous circulation, you warm the blood to a target temperature of 42 degrees centigrade. Now that's pretty hot, okay, but they're sedated, and the temperature, the blood returns to the right heart, and this audience knows the right heart pumps the blood to the lungs. What you may not know is the lungs have the surface area of a tennis court and evenly distribute the heat. Therefore, it goes back to the left heart and perfuses the whole body, including areas like the bone marrow, the brain, and the mediastinum, where other therapies may not reach. We did a pilot study several years ago with advanced metastatic lung cancer. We did 7 patients, achieved 42 degrees centigrade, and we showed that there was a remarkable difference in the outcome of these patients with end-stage metastatic disease. We then took a while to make it refined. We added a dialysis unit to control the electrolytes. We added a blood sorbent to absorb some of the inflammatory mediators. All the components are off the shelf, FDA approved. Don't try this at home though. And we learned how to do this safely to treat the patients. We then control the heat. We detoxify the blood. We normalize the chemistry and the pH, because remember, we can control the CO2, and we remove the inflammatory mediators. So we then said, okay, let's go after failed second-line ovarian cancer, because our in vitro studies showed that ovarian cancer was particularly susceptible to heat. Don't ask me why. So what we showed, that we had a median survival of 645 days with an expected of 267. And we thought, wow, we're still seeing a signal here, right? So then we, in 6 of 10 patients exceeded the expected survival. We submitted this as our second phase 1 study to the FDA, and they said, no comments or reservations. And those of you that have had interactions with the FDA, that's as good as it gets. So now we go on and we said, let's go and treat patients with unresponsive advanced hospice-eligible patients. Now, you guys are in one of the biggest cancer centers in the world. You know they're going to treat most patients, but at some point, they may not respond to therapy. So I said, okay, we'll go after those patients. You treat them with standard of care, give them your chemotherapy, give them your immunotherapy. You can wear them out, just don't kill them, and then let us see if we can get them to respond. Think about it, because there's a lot of patients that reach end of life. So at any rate, we didn't want to treat patients with brain metastasis or stroke or heart attack or uncontrolled blood pressure, or diabetes, or active sepsis, organ failure, excessive metastatic burden, or if they couldn't get out of bed, or if they were over 80. And we learned from COVID, if you're over 80, your immune response doesn't work so good either. So the point is there's a lot of patients like that. So we then said, well, we're going to have to be a little more thoughtful, because we can't always anticoagulate people. They may not tolerate it. And if they have major organ dysfunction, not so good. And if they've just received chemo, we got to at least let them get over that hit, okay? So we then performed all these up in Dallas at First Baptist Medical Center. We put the patient to sleep, so you can rest assured they tolerate it. We do systemic anticoagulation. We then use image-guided insertion of catheters. They're about 13 to 17 French, so those of you in the room are cardiologists or interventional surgeons of any sort, you know that's easy to do. We then put them on venous perfusion dialysis with up to 20% of their cardiac output. We heat them to 42 degrees centigrade for 2 hours, 120 minutes, and then we cool them over about 45 minutes. We take out the cannulas, hold pressure, and it takes about a day to recover from that. So we really didn't identify any complications that were specific to the hyperthermia. We did find, though, that if somebody's already bleeding, if you add anticoagulation, they'll bleed more, so okay, don't do that. And the tumors, when you're so advanced, can distort the anatomy, so we had to have interventional radiologists help us occasionally to place the cannulas. And like I said, it takes a day or two in the hospital. Now, 8 of 13 exceeded expected 3-month median survival. These were hospice eligible now. They were supposed to be, the average survival is 3 months, and the maximum predicted is 6 months. 6 of 13 exceeded that, and 5 of 13 exceeded a year. Again, another strong signal. So we found that frailty, and if you're over 80, and if you can't get out of bed, that's not good. We won't do that. But it does not predictably relieve an obstruction of a hollow viscus or a vital conduit. We got that. But we found that 4 out of 5 deaths before 90 days would currently meet our exclusion criteria. In other words, we're getting smarter. 4 of the 5 patients that died early, we would no longer treat that patient population. So in summary, it's exciting. We've been doing it now for 25 years, trying to get it better and better and better, to tighten the temperature, scrub the blood, be able to control the pH, be able to control the electrolytes, and our last group of patients are promising. So I know this is not standard of care talk. I'm not teaching you about how to treat shock tomorrow, but keep an open mind about how environmental stresses or control of temperature may be able to impact cancers that are unresponsive to all of the therapies. Thank you.
Those are very encouraging results. I can tell you, from the oncologic point of view, when you have a chemotherapy that improves the survival more than 3 months, is a big, big deal. So,
Thank you for saying that. Yeah, the average response to chemotherapy in advanced cancers at this level is about 2 months. That's not widely publicized, but that's what once you've exhausted all the standard of care, that's about all you get out of them. So the signal here is strong. We just got to be smart enough to refine it.
Is there any difference between solid or liquid malignancies for these kind of therapies?
These are solid metastatic tumors.
It's more kind of
Yeah, that's the one in vitro. Those are the ones in the lab. Those are the ones that seem to respond the best. So that actually, it's lung, it's pancreas, it's ovarian, and colon. Those are the 4 that we're targeting.
And have you seen any interaction or any sign between the prior cancer therapies, immunotherapies, checkpoint inhibitors, or in complications with this kind of therapies?
Great question. Numbers are too small. I can't predict. I have to do a larger trial. All of these trials that I'm showing you have been between 10 and 15 patients. Because what we do is we try to refine it, then we do another group of patients, and we try to refine it more. Because I think now, as you could see, my selection process would have dictated better outcomes had I been smarter.
So is this a metabolic effect? What's the mechanism?
Good question. Good question. If you do a complete literature review of all the different theories, some people simply think it's because they don't have adequate heat shock proteins. Some people think it's because of the heat that stops them from replicating. I really can't tell you what the mechanism is. There's a lot of theories, but nothing's been shown proven.
Because if it is a mechanism that's involved with metabolism, the shift, the Warburg effect, or whatever that happens with the switch to cancer phenotype, that happens in end-stage heart failure as well. So there may actually be a very interesting phenomenon that may
That's a great thought. You know, if you want somebody to come to your lab and do controlled hyperthermia on your heart failure model, I'm the guy. Yes, sir.
Yeah, so I'm just curious, what is the pathway then? So this is great. These are people who essentially have no other hope. How do you move that up the chain so that who's going to let you trial? I guess is what I'm saying, standard of care versus...
Well,
versus
as an academic physician, I'm having to choose patients wisely. As you know, patients at the end of life can be somewhat desperate. Yeah. And I'm having to deal the ethics of having patients who are desperate versus patients that I think qualify is probably the biggest challenge.
Yeah. So you'll have to show this in a lot of people before somebody's going to say, okay, let's try it as our third line agent or our second line agent. Correct. And move it up the line. You just wonder, with all therapies, I'm pretty well convinced any effective therapy, the earlier you use it, the better off you are.
Well, as you know, if I start doing it earlier, I'm impinging on the entire world of medical oncology. And I felt like that would put me in an unpopular position with the medical society. So I take patients who've already failed all other therapies, and that way I actually gain colleagues through the oncologist rather than run them away.
So your rates of cooling and decooling are actually fairly rapid and much more rapid than we've ever used with any of our protocols. And so potassium ion shifts would expect to be a problem as you expand your population.
So you hit the nail on the head. There are shifts because of that rapid temperature shift. That's why we do we run it against a dialysate, and that's why we control the pH, because all heat exchangers have a gas exchanger hooked on them, right? So we use the fact that we have a gas exchanger with it to control the CO2. So we tightly control the CO2 and the pH. We tightly control the temperature, and we have it against a dialysis bath for the 4 hours or 2 hours that we're at that heat. So we prevent those rapid shifts.
We have a question for the audience.
Jay, great talk. Marv over here. You know, I think and I'll turn my question into a comment to the point about mechanism. All cells express heat shock proteins. So the real issue is there a change between constitutive versus expressible proteins that may make a difference for your groups of cells? And I think there are a lot of mechanistic things that can be looked at as far as how that modulates apoptotic pathways and a whole other slew of things. It even ties back a little bit to Eddie's last talk about microcirculation, because there could be some definite effects there at the endothelial cell level, which may lead to regional compartment effects or who knows what. But I think the mechanistic things are really what needs to be explored if you really want to advance this therapy.
Well, Marva and I would have been disappointed if you hadn't gotten up and said something. Thank you.
Sure.